Hello, everyone, and thank you for joining us for today's training, Suicide Considerations for Health Center Leaders. I also want to thank our Primary Care Association partners for collaborating with us on today's webinar. My name is Rick Brown, and I am the Director of Communications, Membership, and Special Initiatives with the Association of Clinicians for the Underserved. I'll be your host for today's training. If you have any technical issues during today's webinar, please simply reach out to me or my colleague Jen for help. For those of you who are new to ACU, we are a transdisciplinary membership organization uniting clinicians, advocates, and organizations in the shared mission to establish a robust and diverse workforce to help transform communities to achieve health equity for all. We do that by providing advocacy, professional education, and training and technical assistance to develop and support clinicians and the workforce caring for America's underserved communities. We invite you to learn more about us and membership with ACU at clinicians.org. Additionally, I do want to call attention to the fact that if you're interested in more resources on suicide prevention for patients and clinicians, we also encourage you to visit ACU's Suicide Safer Care page, where you can find a variety of resources from our program, including fact sheets, toolkits, archived webinars, and much more. I'll ask Jen if she can put the link into the chat, and you can also share the scan the QR code on screen to visit the page. Before we begin, I also just wanted to go over a few very quick housekeeping items. First, we will be recording this session, and we will be sending you the recording and slides a short time after the webinar. We also encourage you to ask questions via the chat or the Q&A panels during the presentation, and we'll have a dedicated Q&A at the end of the session as well. As our training concludes, also, I would ask that you please complete our evaluation. It's tremendously helpful to allow us to continue to improve the quality of our trainings. Lastly, I'm pleased to introduce today's speaker. Dr. Verna Little is the co-founder and special advisor for advocacy and research at Concert Health. She is also the chief operations officer and co-founder of Zero Overdose, as well as a member of ACU's advisory council. He's a national expert in suicide prevention, a faculty member for Zero Suicide, and previously served for over 2 decades as a senior vice president for a large FQHC network in New York. We're excited to have her presenting with us today. And with that, I will kick it off to Dr. Little to kick us off.
Well, thank you so much. I'm really glad to be here. I just letting folks know we really want to be able to have some good dialogue, answer questions, have some discussions. So I can watch the chat while we go along. So feel free to actually put information or questions in the chat. We can stop and have a conversation, or I can answer as we go along. So certainly, please feel free to do that. So we're going to spend the next hour or so talking about an organizational approach to suicide safer care. And many of you have joined us for our webinars on suicide safer care for primary care providers, sort of what you can say and do in the course of a 15-minute primary care visit. So if you haven't had an opportunity to do that or would like that for your organization, then please let us know, and we can certainly have an opportunity to be able to do that. So a couple of things we're going to talk about and some considerations. We're going to talk a little bit about patient care and how that folds in. We're going to talk about our team members, and we're going to talk about the community at large. So really thinking globally about what suicide safer care would look like in your organization. So one of the things that I really want to bring to your attention and certainly to think about, and we're going to have an upcoming webinar on suicide care and thinking about prevention among clinicians and our team members very specifically. But the reality is that it's not an if, it's a when. So really important to think about before certainly staff or team member individuals who are dying by suicide. Think about folding it into some of your crisis response and what you're doing. Separate, support individuals from your reviews, and then thinking about your organizational culture to be able to support individuals who were affected by suicide. And we really want to make sure we're thinking about it across the board, organizationally, and sort of all of the different layers and all of the different pieces. So when we think about suicide and we think about the number of people that we're going to lose to suicide and some of the other chronic illnesses or reasons for death that we experience in the health centers, we're certainly going to lose well over 50,000 people this year to suicide. And so thinking about the number of individuals that are in your care that are affected or at risk is going to be really important. And we do focus on primary care settings because I think people in suicide prevention really have a thought that if we can do something different in primary care, we can actually begin to move the needle a little bit more. And that's because many of the people who die by suicide saw their primary care provider in the month of death. And one of the things we've also begun to realize is that individuals who die by suicide who are not connected to primary care, to mental health, to dental, they actually resurface in primary care the month of death. And so really important to know that you have a really important role to play in the identification of individuals that may be at risk for suicide. So we often think about suicide safety and suicide prevention in terms of where people might fall through the cracks. So this is a pretty famous slide used in suicide prevention and from the Zero Suicide website that really identifies places where people might fall through the cracks. And when I think about health centers in particular, one of the places that we see is the front desk. So we had someone die by suicide in Montana, I believe, and she called and she canceled a primary care appointment and like a women's health appointment, and nobody answering the phone knew that she was at risk for suicide, and there was no system in place to know that she had canceled more than one appointment. And so the idea is really thinking about where can people fall through the cracks, who on the team needs to know that someone is at risk for suicide. Like many organizations, schools, now places have handle with care patients. And so maybe when someone is at risk for suicide or is a handle with care patient, then we do something different. If that front desk person doesn't know someone's at risk for suicide, then they can't ask someone different questions. They can't make different decisions. They can't, maybe ensure that that person speaks to someone else before they come off the phone. And so really making sure that you're thinking about places like that where people could fall through the cracks and really thinking about maybe what even happens at your front desk as a place to be able to start. So when we think about suicide safer care, we also talk about Zero Suicide and the Zero Suicide website. If you haven't had a chance to go to this website, it's a really great place for organizations to go. It has lots of information, trainings, things that you can do to really think about organizationally what you could do around suicide prevention. So really encourage you to take some time to go there. So a couple of things to think about as you start to go down this road. One is, how do you know your population of patients that are at risk for suicide? And oftentimes when we go to organizations and we ask, primary care organizations, I was this past week in a room with some federally qualified health centers and talked to them about, tell me what you're doing around diabetes. Tell me about your population of patients that have diabetes. And they said, oh, well, we have this registry and we track A1Cs and we have these benchmarks. And I said, well, tell me how many people you have at risk for suicide. And, across the country, we're finding that most organizations can't answer that question. And so a really important piece, and we're going to talk about a little bit more, is how do you identify and know your population of patients at risk for suicide? So if I asked, you could tell me how many diabetics, you could tell me how many people at risk for suicide. We're also going to talk about clinical pathways and not policies. We don't really do policies. It's really much better to have a pathway. So we're going to give some examples of clinical pathways. We can certainly share them with you so that you can help build them out. You want to maybe build on existing registries. So if you have a registry for depression or diabetes, how could you potentially use those as a foundation for doing some of this work? And also fold it into your quality process. So if you have a chart review process, a peer chart review, and you have certain criteria, maybe if you see that someone is a diabetic or has had a visit to the emergency room, then you do something different, right? You have some different criteria. Maybe you have a different chart review process or some different questions that you ask or things that you look at. And maybe folding suicide care. So if someone is at risk for suicide, you do something different and look at different things during the process of that chart review. And that you're using some evidence-based practices, which we're going to talk about and focus a little bit on what they look like. So we talked about knowing your population of patients at risk for suicide. And this is a really important piece because one of the things that we do is we add information to the problem list. And so fortunately, we live in a world where there's a code for everything, right? We have codes for suicide. We put some of those there on the right for you. And so it's super important to be able to put those codes on the problem list. So what does that do? That immediately gives you a structured data way to know that someone is at risk for suicide. Also, you can then make it historical, right? If someone's not at risk, then you could resolve it and you could make it historical like you do with other problems, or some of them stay. And so oftentimes people will say, well, I'm not really sure that we want to put suicide on the problem list. And this is an incredible opportunity for quality and safety. And I don't think we would be talking about excluding any other life-threatening conditions from being included on the problem list. And I think there's a couple of things to think about, but initially, it's really about the conversation. And one of the things that we want to let people know is, your life is very important to us. And I really thank you for telling me some of your thoughts about suicide today. I just want to let you know that I've noted it here in your chart because I want to make sure that every time I talk to you or my team talks to you or I see you or my team sees you, that we make sure you're safe. And so really preparing and having that conversation. And I think the experience of providers is that people actually appreciate having someone say that to them and having it included so that people, they know people care about them and will ask them and want to make sure that they're safe. I would also say that one of the other pieces to think about is almost two populations. So a lot of times we spend a lot of time thinking about what we do when we initially identify someone. And oftentimes we don't think about what to do for follow-up visits. So if I'm a diabetic and I come in, there's certain things that happen as part of that visit every single time because I'm a diabetic. And so one of the things that you want to think about is what is the expectation for a follow-up visit for someone that's at risk for suicide? So maybe it's just asking whether or not they have a safety plan, whether or not it needs to be reviewed. And there's some other questions that you can ask and we'll talk a little bit, but really thinking about what is it that you expect to happen on the first time when you identify someone and then on subsequent visits when they come back. And it's really important to be able to have those processes down and then also to really put in some expectations. And one of the things that we know is that if you don't actually put in the expectations, then things aren't going to change in terms of what happens organizationally. So think about the adolescent that goes into a school-based health center and he's going to get some forms filled out to play football. And he gets identified as being at risk for suicide. Lots of commotion, somebody talks to him, they give him a referral out for care. His mother comes and gets him and brings him, to an urgent appointment. And he comes back 3 weeks later and he still has his forms for football. He sees a different provider. Suicide is not on his problem list. He's in and out. Nobody asked him about suicide. Nobody asked him if he's safe. And so that happens all the time in our centers because we don't have systems in place to put suicide on the problem list or what to do in terms of a follow-up. And the same thing sort of goes with identifying people. So one of the efforts has been to turn, the banner red on electronic health records as an example. And what I found in my experience is that actually does not change provider behavior at all. And one of the reasons that it doesn't is because we haven't been really clear about what we expect someone to do when they see that red banner. What is it that I'm expected to do differently? And so unless you're really clear and articulate that, then what happens is going to be a little bit all over the map and going to be very specific to that particular provider. So a couple of things to think about as you're, doing some of this work is that you really want to try to put in some information to identify people that might be at risk. So, for example, what we know is that many people who die by suicide don't have a mental illness at the time of death. That's huge. It's very different from how I was trained. What we know is that the social determinants play a huge role. The housing, the finances, all of those things. So if someone has multiple social determinants, then maybe we ask them about suicide. And we want to ask directly what we want to know. We want it not, are you okay? Are you thinking about dying by suicide? We want to ask very specifically. We also organizationally don't want to count on our depression screening programs and processes to identify people at risk for suicide. It is one way potentially, but it is not the only way. And oftentimes, many people who die by suicide don't have depression, and many people with major depression are not suicidal. Anxiety is a huge risk factor for suicide. And so if we only focus on our depression screening to identify people, we're going to miss a lot of people who may be at risk for suicide. Even though we know that people who answer question 9 on the PHQ-9 are more likely to die by suicide, there's actually been research that have shown is that's the only question you ask, that you miss quite a few people who are actually at risk for suicide if you had asked them directly about suicide. And we know also that particularly in the adolescents, and what we know is that adolescents are actually at huge risk for suicide these days, particularly your 10 to 14-year-olds. You want to ask them very directly about suicide. We also know that transitions are a huge time of risk. Oftentimes, we're just paying attention to people coming out of the hospital, but out of incarceration, foster care, substance abuse treatment, all of those are actually putting people really at risk for suicide. So we really want to make sure that we're talking to them. If we have a process that is transitions of care for when people are coming out of the hospital, we should automatically be adding to that and asking someone about their risk for suicide. So one of the things that we also want to do is start to think about how are we going to, oops, the slides are a little nuts. How are we going to really identify people at risk for suicide, and what are we going to do? So what we've started to do is build pathways off of the Columbia scale, which many of you are familiar with. This is in all of the electronic health records, and we only use this version, or what we affectionately call the primary care version, and think about processes that actually go based on this yellow, orange, and red. Because one of the things we've learned is, we used to say, well, somebody, patient has suicidal ideation and a plan, and, off they would go to the emergency room. And we now know that's not great care, right? Because I can think about suicide. I can know how I would die by suicide. But what really is the risk is whether or not I intend to die by suicide. Do you intend to carry out this plan? Have you had these thoughts and had some intention of acting on them, right? So if I'm positive to 4, 5, or 6, then you want to maybe do something different. But there's things that you can do organizationally as a response for your yellow and orange patients. So as you're thinking about a pathway, you can actually base it, because one of the things we've learned about risk is we used to think like you're on a suicide risk pathway or you're off, like you're at risk or you're not. But really there's varying levels of risk, and we want to make sure that we're doing really high touch things and something different for the people that are at the most risk, and something a little less for the people who are at the less risk, just like we would do for any other population, right? We start to think about it very much the same way. And so this is a little bit about what a pathway might look like, and we'll share, and we have actually a newer version that we can share with you out. But one of the things to start to think about is for our different levels of patients, what are some of what I call fixed variables, right? Things that we might want to do differently for individuals. So for people who are, have intent or at high risk, maybe we want to have some contact with them once a week. Maybe people who are orange or at medium risk, maybe it's every 14 days. We want to make sure that we give a follow-up within a certain amount of time. We want to make sure that we do something different if they miss an appointment. So if someone at high risk misses an appointment, maybe we call their emergency contact, where somebody at a lower risk misses an appointment, we leave a message and we try them back before the end of the day. So we're doing something different sort of based on the risk level. And so part of what we've really been working with organizations is to really identify ways to be able to stratify their risk and be able to do something different based on the kinds of services and support that someone might need. And so we're glad to share these pathways out with you. For example, I know oftentimes there may not be enough behavioral health providers. We talk very specifically about what providers can do for those yellow patients to be able to give them information and resources so that they can care for them. And we know, again, the PHQ-9 or screening for depression is not the only thing that you should do. If you look here at the bottom of the PHQ-A, there's actually some very specific questions on suicide, which we really recommend. If you're going to ask an IMH, they're going to tell you really ask everybody ages 10 and up so that you can do this. And we'll share some of that information. And yes, for someone just asked, we will be sharing out the slides. So this is the ASQ, and this is actually the questions that are on the bottom of the PHQ-A that you just saw. I like the ASQ. Maybe Jen could actually put the link in the chat. If you go to the NIMH website, you can literally Google NIMH ASQ, and it will come up, and there's a toolkit there. I like it because it has a script for nursing and a script for parents or guardians. And it's really nice to help you put in like a phone process for your organization so that if someone calls, you can actually use this questionnaire with them. I like it for children and adolescents. I think it's easier to use. Are you having thoughts of killing yourself right now? Like, that's a super easy question. And then we can know what to do from there. So oftentimes organizations will put these questions on the bottom of the PHQ to really screen their children and adolescents very specifically for suicide. It's just really helpful way to be able to think about it. The ASQ is not in as many electronic health records. However, it is a little more research for children and adolescents. There is also now this Columbia scale for children and adolescents. It is actually new. It's come out in the last year. It is not in the electronic health records. Sometimes what organizations say is we really just want to use one, tool, and we're going to use our yellow, orange, and red. So what you could actually do is use the ASQ for your phone triage, use the ASQ as a screening. And if someone says yes, then you would do the Columbia scale, particularly for the children and adolescents. So that's actually something that might be helpful for you to really think about, doing that. So those are just some brief overviews to really think about for your patients in terms of really coming up with a pathway. Because one of the things we know is that it's going to be important for you to address suicide across your entire organization. And so unfortunately, we lose a physician a day to suicide, and many of the people in healthcare don't actually get the care or treatment. And this project, this webinar, is part of a larger project where we've trained now, I don't know, it's got to be just under 4,000 primary care providers and their teams in, I don't even remember, 30 some states now. And I didn't go into a single residency program or single medical school where someone didn't come up to me and tell me about someone that they lost in residency or med school to suicide. Not one single one in any state. And so one of the things we've seen is that many of the younger, newer primary care providers are actually more interested in learning about suicide care because they've experienced it firsthand in their patients or in their training. And so we do know that we are losing, medical providers, residents. This is just physicians, not counting residents or medical students. I was actually in a practice not that long ago, and I asked them, have you been affected by, suicide and losing any staff to suicide? And they proceeded to rattle off. She was literally like this, well, we lost a nurse practitioner, and before that we lost a lab tech, and before that, so it had been multiple people that they had lost to suicide, like a larger organization, but still, I was actually shocked at the number of people that they had lost to suicide. So again, if you're one of the teaching health centers or you do some of that work, I know one time when I worked in the FQHC, I had a very hard time getting my, chief medical person to really pay attention to suicide among the residents, and really thought we should bring about it and talk it. And so one time I actually asked them at rounds and collected them back anonymously. And I think he was really surprised at the number of people who had or were having suicidal thoughts at that time. And so I don't think we've gotten better. I think it's actually gotten worse. And I think it is still really thoughts out there that if I say that I need care, or if I say I'm thinking about suicide, that's going to hurt my career. It's going to hurt my chances at residency. It's going to hurt my ability, to be a provider. And I think that has not actually changed. Because many of the physicians or the primary care folks who die by suicide, they're not engaged in mental health treatment. They're way less likely to seek mental health treatment. Some of it is scheduling and residency, but they're just way less likely to go and to access care. The other thing I would start to think about is how you're sharing information. I would really encourage you now, if you had someone that died by suicide who was a staff member or who was a patient, how are you going to communicate that information? I really encourage you to draft an email now and to think about an email now that your CEO would send out if you lost a team member to suicide, because it's really important. And it can really impact how that information is spread and what your organizational response. And I think, it's important to talk about suicide. It's important to say suicide. And I know there's always some hesitancy, unfortunately, to do that. But it could really be a missed opportunity. And that's something that you really want to start to think about. So I would actually talk about drafting that email now. Unfortunately, no one really looked at suicide risk among nurses until about 4 or 5 years ago. And people were shocked. And I think I didn't necessarily feel shocked because I kind of just had been working in healthcare, and doing some of this work. But when you think about particularly female nurses, 23% more likely to die by suicide than the general population. That's huge. And so we really need to pay attention and to have some of this information. How are we keeping our nurses safe? How are we talking to them about suicide? And suicide in general is much higher in healthcare workers. And so we really need to know that and to understand that. And how are we thinking about that as an organization? And I think that that's really an important piece. And if we don't talk about suicide, then we're not creating an organization where people talk about suicide. And that's really an important piece. And I think, right at the beginning of COVID, someone actually did an article about an ER provider who died by suicide. And I think that started to create some dialogue around the risk and the need to be able to respond to suicide. So when I think about organizational response, we don't actually get trained on what to do across staff, right? And so one of the things that's really important is to understand that when someone dies by suicide, everybody who might be at risk for suicide becomes more at risk. So if you already have individuals on your staff that are at risk, they're going to be at more risk. If you already have patients who are at risk, then they are going to be at more risk. And so I recently worked with a FQHC, and they had very high profile adolescent death. And one of the things that they talked about is, well, what do we do? And they didn't actually know any of the adolescents in their system that were at risk for suicide. They didn't track it. They didn't know who they were. And so it's true that every adolescent becomes more at risk, but they realized at that point, like, hey, we really need to know this. So if something happens, we have the ability to respond. And we don't really train people. We don't ask organizations about suicide, and we don't teach managers how to respond. And so I can tell you, I had a manager call me one time and say that someone on her team posted a suicidal statement on Facebook, and that they went to get her off the floor and brought her. And I said, okay, well, where is she now? And they said, we put her in the supply closet so that she couldn't go anywhere. Like, you can't even make this up. And that was really an organizational fault, because we had never trained that manager. What do you say? What do you do? Right? So that's something to really think about, to be able to let managers know, hey, thank you for telling me you're thinking about suicide. Your life is very important to us. And then give them a way to be able to respond, right? So when I worked in health centers, we used to do this thing called the hazardous vulnerability analysis. And we used to do crazy things, like we used to say, what? Because I had a lot of slots on it, right? And we used to say, well, gosh, how could we fill it? Well, what if a subway train went off of the L and crashed into a health center? Like, because we had to fill this whole thing out. And then one day I said, you know what, actually, we should start to think about it a little bit different, because really having someone die by suicide should be on our HVA, because we do need a coordinated response. And so we've really started to include it in our hazardous vulnerability assessment for the organization. And many times also, when we're doing some of this work, we don't include human resources. And oftentimes people will reach out to human resources, or someone will make a suicidal statement. I've had people call when they were terminating people and say, I was terminating this person's employment and they made a suicidal statement and I didn't know what to do. So really training those individuals, and also thinking about your policy. So oftentimes, I know we had a policy in an organization one time, as many organizations do, like a no call, no show, right? So if you don't call and you don't show for 3 days, you get a termination letter. Well, what if that person died by suicide or is at risk for suicide? Like, do we want to do something differently? So do we want to outreach? Do we want to express some concern for them? What does that look like? And also, is your employee assistance program, are they trained to actually care for people at risk for suicide? So if you're going to do some of this work and you want people to talk about suicide, and then they go to an EAP program who doesn't really know how to care or what to do with people at risk for suicide, then that's going to not be that helpful. So when we think about what that looks like, we want to try to be able to do that. So we want to start to think about management training, right? To let them know, listen, you play a really big role in what our response is. And so if you notice that someone is struggling, ask them. So I've had so many people who have said, oh yeah, so there's a nurse practitioner who died by suicide. And I was talking to the health center and they said, we knew she was going through a really bad breakup. We knew that she had lost her dog. We knew that she was having financial problems. Like, they knew all of those pieces. And so really thinking, we didn't ask her about suicide, even though it turns out that she actually gave away some items before she left on the last day. And so we know that it's not easy to talk to someone about suicide, but we also know that if we overwhelmingly, we don't give someone an idea, right? The research is really clear. A lot of times people say this about kids. So I'm going to talk to kids about suicide, right? Because I don't want to give them any ideas. First of all, unfortunately, our kids already know about suicide, but the research says you're not going to give them any ideas. And so you want to start to give people language, that says sometimes people who are having some struggles like you are start to think about suicide. All of our employees are really important to us, and I want to make sure you're not thinking about suicide. So you're asking very clearly and very directly about suicide, but you're giving your managers language so that they have something that they can actually use. And you want to try to give them a guide. And one of the things to do is to actually really work with them and give them a chance to practice. What would you do if someone made a suicidal statement? What would you do if someone came to you and said someone made a suicidal statement, or that they saw someone had a post on Facebook that was suicidal? What would you do if someone didn't show up for work, right? What would you do so that you can really give people language to be able to respond, so that there's something in place for them? Also, one of the things to think about is right up front when you're onboarding people, to let people know, listen, we are not going to have access to those records, right? That's not something that we're going to do. It's not going to impact or change your ability to get a promotion or for your career. To let people know what the services cost, because oftentimes, particularly for some of our frontline staff, that's a huge issue. So letting them know, what will some of those services cost? Will someone know if I use the employee assistance service, and what does that look like? And what does it look like to get care? How will that be? And so if you did an FAQ like this and you gave it out to individuals joining your organization, that would be incredibly helpful for them. And it would also say, hey, we're the kind of organization that you can approach and talk to us and get this information. And we feel pretty strongly, and we want you to be able to have it. So when we think about some trainings, there's a couple of things that are like super tempting to be able to do. We want to try to avoid these one and done trainings. Often not particularly helpful. And so how are you really going to bake some of these things into your organization? What are you going to do for existing versus your new staff? So if I'm a manager now, or I'm a manager that joins your organization 6 months from now, how am I going to know what to do? One of the things that I know organizations often do is, during onboarding, they'll do something around suicide or suicide care. And oftentimes that's not super effective, because it's not, one is, people are just coming into an organization, they're learning where the bathroom and the coffee pot is and how to use the computer. So oftentimes a lot of this other information doesn't stick. It's just really checking a box. But it's often really helpful to wait a little bit and then do some specific trainings for different departments and give very specific examples. So, there are examples of someone who was called billing to talk to them about an overdue bill and made a suicide statement. There was a facilities person that found a note. There was a primary care provider or human resources, so that you're giving examples that happened in the organization, so that they can talk about them, respond to them, and understand that this information does apply to them. And that is sort of not this one size fits all. And how can you have some trainers and sort of continue to be able to do the work? One of the things we've learned with some of the clinical training is that it's really better to wait a little bit, because oftentimes you get the onboarding and then the next day you go and you learn how to use the EMR. It's actually better to wait a little bit and then talk to someone about how you care for individuals at risk for suicide, and then teach them in the EMR at the same time, so that it comes together and they're getting everything together all in one place. And then how would we know that our trainings are successful, right? How would we know that what's happening on the front lines has changed? How do we know that people are being asked about suicide, or that we're really changing some of the conversations that are happening at some of the front lines and in our practices? And when you think about trainings, think about listing all of your departments and all of your job titles. and really engaging the senior leadership, right? And one of the things you can do is you can list all of the job titles and then think about what training do people need. Maybe there's some folks that are non-patient facing that just need one training during employment versus maybe folks who are clinicians and caring for individuals, and maybe they get multiple trainings around safety planning and using the Columbia scale and, you know, all of the other pieces that they might need. And maybe you do some sort of ongoing training with them and really engage the senior leadership, letting them know why it's important. Your staff are community members as much as they're members of the organization, and every single person could have identify somebody or come in contact with someone that's at risk, whether it's another team member or whether it's a patient or whether it's a community member. And I think it's really important to try to get people to give some, you know, specific examples from their, you know, place or their line of business. And then really think about how you're going to track and how you're going to train and how you're going to reinforce some of that information. And there's lots of good examples out there now that we can certainly talk about. And then when you think about suicide safer care, really thinking about, you know, top to bottom and bottom to top. So really engaging the senior leadership, talking about, you know, what needs to happen organizationally, and really teaching, you know, middle and line clinicians what happens. And, you know, I had someone die by suicide one time, and the last person they saw was the insurance enroller. And so really thinking about how do we engage everyone, because everyone has a role in keeping everyone safe. And that this is not a project you're going to take on and then it's going to go away. This is sort of what it's going to look like in your organization, that you're going to develop a population approach for new patients and for ongoing patients and those patients returning, that you're going to think about how does suicide care fold into our quality improvement, into our safety, into our emergency preparedness, into our technology, into performance, into our staff training, into our manager training. What does that look like? Who are some champions? Do we have a champion in HR? Do we have a clinical champion? You know, what does that look like? And be really clear about what some of the expectations are. If you have a pathway, what does it look like? How do we know that it's followed or that it isn't followed? Think about bringing the work up during supervision, whether it's with your residents or your behavioral health providers, right on at the entry to the organization. Think about ways that you can communicate out with some wellness on some of the computer messages, or you get Lifeline and information on entry with human resources, that you have some benefits that encourage, you know, wellness and talk directly about suicide. And suicide is a word that we say. We talk about suicide, we ask about suicide. Those are conversations that we have with our team members and our patients. And I would say probably one of the most common is getting suicidal statements. Someone, you know, makes a suicidal statement or posts it on social media. Or we've often, you know, I had someone call one time and say, listen, I'm really concerned about my wife. You know, she's been feeling very suicidal. I would appreciate if you could watch her at work, right? And so we really needed to have some different conversations. It's important to practice at staff meetings to be able to say, listen, what would we say if the person next to you at the lunch table said that they were thinking about suicide? Or what would you say to someone if you felt like they might be at risk for suicide? You know, what would you say? And then practicing it with people and practicing it at the staff meeting is going to be incredibly helpful for people. So I wanted to make sure we left a little bit of time for some questions. I know that there have been some questions in the chat. I'm actually going to go back and answer some of them now. So I think when we look at between caring and attending to staff's emotional and safety needs, you know, if someone is potentially at risk for suicide, you know, if someone's life was threatened, we would want to make sure that we intervened. It doesn't mean that we might, you know, provide ongoing care for them, But certainly if someone wasn't feeling well, we would intervene. We might give them an EKG, we would take their temperature, we would ask if they were well, and then we would put a plan in place. And so very much the same, you seem, you've mentioned that you've had some thoughts about suicide and, to ask someone and talk to them very directly. So I think very much the same as we might do for other scenarios. So I think mental health first aid is really good. I think it starts to open the dialogue. I think you need to take it a little bit further and really practice. We teach something we call storage statements, which are things that you can say when someone tells you they're thinking about suicide, and you can practice them. So, thank you for telling me you're thinking about suicide. Your life is really important to me, so that you have some responses. So I think mental health first aid is great to be able to roll out across your team, but I think it's also important to try to practice some of those storage statements as well. Any other comments, thoughts, questions? So one of the things, let me just pull up the question. What if a staff member shares with their supervisor that they're experiencing suicidal thoughts but ask for confidentiality? So one of the things is to, use your storage statements, thank you so much for telling me you're thinking about suicide. And then, what we do is we train those individuals to ask very specifically, right? Because you want to know, is that person at imminent risk, where you need to do something? So you could use the Columbia scale or you could use the ASQ. And if someone, has intent, then you need to engage someone else, and they likely need to have some sort of a formal evaluation, or maybe you could just get someone connected to EAP or to some other resources, but it's kind of like if someone was at imminent risk, right? Like we want to protect someone's confidentiality, but if they're at imminent risk, then we need to make sure that they're safe. I remember one of my team members had a heart event, right? And so you want to, make sure that they're in a private area. You want to respect their confidentiality, but you're going to do what you need to do to treat them and make sure that they're safe. So I don't think 988 has something sort of very specific to this, but we can actually share a booklet that we have. So we're at square one and have never implemented suicide safer care. Are there examples of language or flyers? There actually are on the Zero Suicide website that you can pull from. That actually would be really helpful for you. So I might start there. And then also the ACU Suicide Safer Care landing page has a lot of information and some booklets as well that would be helpful for you. Some really great questions. Just encouraging people to put any questions in the chat or ask any questions. You can always reach out to us, as you go forward and do this work. If you want to reach out to us, you want to have training for your team members, then please reach out to us. We'd be more than happy to share information. We'll share the slides. Glad to also have some individual meetings with you and some of your leadership. Also, reach out to us and let us know.
Dr. Little, it looks like we've had another question come in from Dr. Cheney. You see that in the chat?
Do you foresee any challenge with a flexible frequency of screening Hold on. Yeah, so no, I think if you have someone and they, don't score positive on questions 4, 5, or 6, then certainly that period of 3 months, absolutely. I think after that you can change the 3 months. I think that that's fine. Because what you really want to know is you first want to know in your lifetime ever have you, right? And then after that, you want to know since the last time we talked. And then, if that's what I hear you saying here is if that's negative for 3 months, can we do something different? And that would be yes. You've just you okay. Yeah, we'll send out a copy of the slides. Absolutely. Okay. So again, I really encourage people to follow up with us. I really appreciate your time today, all of the questions, and always good ability to have some discussion. Hold on. Let me just go back to this question. My organization is part of the Zero Suicide Initiative, and we're stuck between 30 and 90-day screenings, but it sounds like we don't have to commit to no. And I'd be glad to talk it through with you. If you want to shoot me an email, I think it might be helpful to share the latest pathway with you. That actually might be helpful. So we're glad to follow up with you if you want to do that. Yep, and I'm actually going to be training the South Carolina primary care providers. Yeah. So thanks, Tanya. Yep, looking forward to doing that. We got that coming up in September. So if folks want to shoot us an email, we can send you the latest pathway, but that screening question that just came up, I actually think this new pathway will be super helpful for you and kind of solve that problem. So please, I'll actually put my information in the chat. And if you send me something, I'll send that pathway out to you. Okay, well, everyone, thank you so much. I appreciate it. I look forward to hearing from all of you, and we'll get some of that out to you. Thank you, everyone. Have a wonderful day.